Hello everyone. Today we are dealing with part 2 of chapter 1. So let's start. This table is very important for the students who are preparing for PG. So this is about the volume of intracellular organelles present in the cell. For example, 54% of the cell is composed of cytosol and it helps in metabolism, transport of proteins and protein translation. Mitochondria, the number of mitochondria per cell are 1700, which comprise to the highest number of organelles present in the cell. It helps in energy generation and apoptosis. Rough endoplasmic reticulum, it helps in synthesis of membrane and protein export. And smooth endoplasmic reticulum, it helps in protein modifications and catabolism of protein. Nucleus, as we know, nucleus helps in cell regulation, cell proliferation and DNA synthesis. And lysosomes helps in cellular catabolism, that is catabolism of several proteins and catabolism of other organelles. Peroxisomes helps in very long fatty acid metabolism. Okay, this is asked in NEET PG several times. For a cell to function normally, the cell has to transduct various signals. So whenever the ligand binds to the receptor, so this is a ligand and this is a receptor. So whenever this ligand binds to the receptor, so this mediates various signaling by cross-linking the other receptors. So cellular receptors are of several types. We will see about them one by one. And these receptors are based on signaling mechanisms they use and the intracellular biochemical pathway they activate. So depending upon them, the receptors are divided into several types. So the first one is tyrosine kinase receptor, okay, which is the most commonly heard one, and it is an integral membrane protein, which means it resides within this bilayer. So as you can see, it is passing through this bilayer of cell membrane. Okay, so tyrosine kinase is an integral membrane protein, and when a this ligand attaches to the receptor, it activates the intrinsic domain which is located in the cytoplasm, and thereby phosphorylation takes place. Examples of these receptors are insulin receptors, epidermal growth factor receptors, and platelet derived growth factor receptors. Okay, so please remember all of these examples of the receptors. They can be asked in NEET PG. And mutations of tyrosine receptor is seen in CML and GIST. Okay, and the other one is non-receptor tyrosine kinase. So this one is a non-receptor tyrosine kinase receptor. So this non-receptor tyrosine kinase is not an integral membrane protein, as it is seen in the image that it does not pass through any membrane. It is present within the cytoplasm. It does not have any extracellular ligand binding domain also. This phosphorylates the tyrosine residues within the cell. Okay, and the third one is G protein coupled receptor. So these G protein coupled receptors will traverse the plasma membrane 7 times. Okay, so like this, it is 1, 2, 3, 4, 5, 6, 7. Okay, it traverses the plasma membrane 7 times, and after binding to this ligand, GDP is converted to the GTP in the downstream. To this results in the generation of cyclic AMP and adenosine. So where GDP is converted to the GTP and ATP is converted to the cyclic AMP and adenosine triphosphate, thereby releasing the calcium, and this transcription takes place. And fourth one is nuclear receptor. Okay, any lipid soluble ligand. Okay, because this plasma membrane is lipid bilayered, so anything which is an lipid soluble ligand, it can diffuse into the cell, and they interact with the intracellular protein to form the receptor ligand complex, and this will directly bind to the DNA, nuclear DNA, resulting in the activation or repression of transcription. And Notch family receptor. Notch family receptors, where this is a ligand and this is a notch receptor. So this notch ligand will come and bind to the notch receptor. This leads to the cleavage. Okay, for the notch ligand to get activated, it should first cleave. So this leads to the cleavage of the receptor, and subsequently this notch will directly go and bind to the DNA, leading to the transcription of the target gene. And this is an frizzle receptor. So Wnt is a ligand. So this Wnt will come and Wnt ligand will bind to the frizzle receptor, leading to the disruption of this multi-subunit complex. So we will learn this in detail in chapter neoplasia. But for as of now, you remember that there is something called as a multi-subunit complex which is present in the cytoplasm. Okay, and whenever this Wnt ligand comes and binds to the receptor, this leads to the disruption of this subunit complex, leading to the release of beta catenin, and this beta catenin will go and bind to the transcription factor, leading to the finally transcription of DNA. So mutation of this Wnt gene or beta catenin is seen in FAP, familial adenomatous polyposis. Whenever this growth factor binds to the receptor, so this causes first the phosphorylation. So following phosphorylation, this binding protein comes and attaches to this couple, okay, the receptor and an inactive RAS. So binding of this binding protein leads to the activation of RAS, that is when GDP is converted to the GTP. So conversion of GDP to the GTP leads to the activation of RAS and activated tyrosine kinase, then subsequently activates the following pathways, that is PI3K AKT signaling pathway or RAF MAPK signaling pathway. So this cascade is turned off whenever GDP is converted to the GTP is converted to the GDP. So whenever there is a mutation, this leads to the delayed GTP hydrolysis. So that is why greater proliferative signaling takes place whenever there is mutation in the RAS. So next is the types of receptors and their functions. We will see in detail one by one. First one is EGF and transforming growth factor receptor alpha. This EGF and TGF alpha both belong to the family of EGF only. There are four membrane receptors belonging to this family, and EGFR1 is also known as ERB1 or ERB1, and mutation of this is seen in various lung cancers, head and neck and breast cancers. And ERB2 or is also known as HER2, and mutation of this is seen in various several subtypes of breast cancers. The next one is hepatocyte growth factor. So this HGF helps in morphogenesis, which means it helps in tissue as well as organ development during embryogenesis. And it is also called as an scatter factor because it promotes migration of the cell, and this receptor for this hepatocyte growth factor to act is called as an MET. So MET is the receptor for this HGF, and this MET receptor, this mutation of MET is well known, and it is well read in renal as well as papillary carcinoma of thyroid. And clinical application of this is MET inhibitors are helpful in if renal and papillary carcinoma of thyroid treatment. So next is platelet derived growth factor. There are three isoforms of PDGF, that is AA, AB and AB. So as the name suggests, platelet derived growth factor, it is stored in the platelet granules and it is released on platelet activation. So whenever the platelet get activated, PDGF is released, and thereby recruitment of other platelets takes place. And it also induces fibroblast, endothelial cells as well as smooth muscle cell proliferation, and it acts as a chemotactic factor during inflammation, which means it promotes the recruitment of other leukocytes and neutrophils to the site of inflammation and tissue injury. The next is vascular endothelial growth factor, that is VEGF, and VEGF A, B, C, D and placental growth factor belongs to this family. So the first is VEGF-A. This VEGF-A is a major angiogenic factor in injury as well as tumor genesis. And VEGF-B and placental growth factor are more major angiogenic factor in embryonic vessel development. And VEGF-C and D helps in angiogenesis as well as lymphangiogenesis, which means lymphatic development. And this VEGF not only this VEGF not apart from this angiogenesis, it affects vascular dilatation as well as it increases the vascular permeability. Hypoxia is an important inducible factor for the production of more of this VEGF. That is, whenever there is an hypoxia, then there is an activation of transcription factor called as an HIF1, which is hypoxia inducible factor 1. This leads to the increased release of vascular endothelial growth factor. And clinical application of this VEGF, there are various antibodies which are developed against this VEGF, such as antibodies against VEGF are used in renal and colon cancers, where they require angiogenesis for the growth development as well as metastasis of the cancer. So if we treat this with the VEGF, then we can reduce the tumor burden, as well as metastasis can also be reduced to some extent. And age related macular degeneration, where there is inappropriate angiogenesis is taking place. Retinopathy of prematurity, where a lot of angiogenesis is taking place due to the hypoxia again. And diabetic macular edema, where diabetic retinopathy leading to the in diabetic retinopathy, the vessels are leaky vessels, that is in the vascular permeability of these vessels is increased, leading to this condition. So this can also be treated with the antibodies against VEGF. And VEGF R1 are also increased in the conditions, that is preeclampsia. So the next is FGF, which is fibroblast growth factor. There are various FGFs. So the most commonly known are this acid FGF, that is AFGF, also known as FGF1, and basic FGF, BFGF, also known as FGF2. So in extracellular matrix, what happens? This FGF is associated with the heparin sulfate, and it acts as a reservoir for the inactive factors, and it is released by proteolysis. For example, its function mainly is in the wound healing. So in extracellular matrix, so this is in cell, this is in cell, and there are these extracellular matrix which are present outside the cell. So this fibroblast growth factor is present in this extracellular matrix component always, and it is associated with the heparin sulfate, which is an inactive form. So whenever there is a tissue injury and subsequently an repair or a healing should takes place, so this FGF is released following proteolysis to its activated form. Thereby it helps in wound healing. The next is TGF beta, which is also called as a transforming growth factor beta. The isoforms of TGF beta, TGF beta are TGF beta 1, 2, and 3, and among which TGF beta 1 is the most abundant form. So this is secreted as an precursor, thereby it is activated by proteolysis. This proteolysis yields the active form of TGF beta. So TGF beta induces the phosphorylation of various other cytoplasmic transcription factors such as SMAD transcription factor, and this leads to the nuclear transcription and thereby activation or inhibition of the transcription. The primary action of TGF beta is scar formation. Okay, the main function of whenever there is a scar is formed, then it is because of release of this TGF beta. So TGF beta stimulates the production of collagen, fibronectin, and proteoglycan. Why? Because this collagen, fibronectin, and proteoglycans are important for the scar formation. So this stimulates the production of all this collagen, fibronectin, and proteoglycan. It also inhibits the collagen degradation. If collagen is, it inhibits the collagen degradation. How? By reducing the matrix metalloproteinases. So matrix metalloproteinases function is to degrade the extracellular matrix component, where collagen is one among them. So if we reduce the function of this MMP, thereby we increase the synthesis as well as function of this collagen, and we are increasing the inhibitors which inhibit this metalloproteinases, thereby indirectly increases the collagen synthesis and reduces the collagen degradation. And it not only helps, or it not only helps in formation of the scar, but also the fibrosis of the lung, liver, and kidney. That is, whenever there is a chronic inflammation taking place in this organs, such as tuberculosis of the lung or cirrhosis of liver or chronic kidney disease, then the fibrosis is taken place by this TGF beta. And anti-inflammatory cytokines, that is, it acts as an anti-inflammatory cytokine, thereby limiting or terminating the inflammation. That is how, by inhibiting the lymphocyte proliferation at the site of injury. So this is the same table what I have explained till now. Okay, please try to remember these things which can be asked in a NEET PG, and the same thing. So the next is extracellular matrix. The functions of extracellular matrix are: it helps in mechanical support for the cell, and it helps in regulation of cell proliferation. It acts as a scaffolding or a support for the tissue renewal, and it helps in tissue microenvironment. That is, it not only provides the support to the epithelium by as a basement membrane, but also it has a specific function. For example, in kidney, it forms a part of filtration apparatus. This extracellular matrix occurs in two forms: interstitial matrix and basement membrane. So this is a picture from the Robbins. Uh, uh, as the name suggests, interstitial matrix, which means a tissue or a space which is present between the cells, are called as an interstitial cell, interstitial matrix. And this components of interstitial matrix are collagen, elastin, proteoglycan, and hyaluronan. And the other one is an basement membrane. Basement membrane, this is an basement membrane present underlying this epithelium as well as endothelium. And basement membrane helps in maintenance of tissue polarity, which means if a cell has to maintain its nucleus, where the cell is settled in the nucleus and cytoplasm is above this, so this is called as an polarity of the cell. If the cell has to maintain its polarity, then a basement membrane plays a very important function. And the components of basement membrane are type 4 collagen, laminin, and proteoglycan. First we'll learn about the collagen synthesis. So, collagen, there are about 30 types of collagen present in the body. So, initially what happens? Initially the signal takes place in the nucleus where DNA is synthesized to an mRNA, and this mRNA gives a signal for the synthesis of the collagen. So these alpha chains. These are the alpha chain. So these alpha chains of collagens are synthesized as a precursor form of collagen. Okay, initially there's a precursor form of collagen which is activated to form an activated collagen form. So initial processing takes place in this endoplasmic reticulum. So these alpha chains undergoes hydroxylation as well as glycolization to form this kind of an triple helix. Okay, the alpha chain undergoes hydroxylation and glycolization to form an helix. And for there are two types of collagen, that is fibrillar collagen as well as non-fibrillar collagen. So this, for all the fibrillar collagen, this carboxyl end is completely removed by endoproteinases activity, whereas this N terminal is variably processed. Matlab, it is processed in some type of collagen, and it is processed in not in, it is processed completely in some type of collagen, and it is not processed completely. So depending upon that type of where the N terminus is variably processed depending upon the type of collagen. After secretion, activated form of collagen, it undergoes a cross linking by oxidation. So this collagen is undergoing this cross linking by oxidation process, which is an lysyl hydroxyl oxidation, which provides an stability to the collagen. Collagen undergoes this cross linking, which provides an stability to the collagen by the process called as an lysyl hydroxyl oxidation. And any defect in this steps of collagen synthesis, such as this primary sequence synthesis or this pro-collagen processing or collagen processing, or if there is any defect in this cross linking, then all this leads to connective tissue laxity, and the disorders related to this we will study further. So there are about 30 types of collagen present in the body, and as I said, there are majorly divided into two types: fibrillar and non-fibrillar type of collagen. So the types of fibrillar collagen is type 1, 2, 3 and 5. Okay, and they are called as an fibrils, where they form some linear they form a linear fibrils like this, and they are stabilized by the hydrogen bond which is present between them. Okay, and the major proportion of connective tissue, uh, uh, and so these kind of collagen forms the major proportion of connective tissue in the bone, tendon, cartilage, blood vessels and skin. And also this fibrillar type of collagen helps in wound healing and scar. So the enzyme required for this cross-linking is lysyl hydroxylase enzyme, and this lysyl hydroxylase enzyme is dependent on the vitamin C. That is why children with ascorbate deficiency have skeletal deformities, and individuals of any age with vitamin C deficiency have poor wound healing and they bleed easily. And any genetic defects in this collagen synthesis as well as lysyl hydroxylase causes an osteogenesis imperfecta and Ehlers-Danlos syndrome. The other type of collagen is non-fibrillar collagen. And the major component of this non-fibrillar collagen is in type 4 collagen, which is present in basement membrane, as well as type 7 belongs to the non-fibrillar collagen, which type 7 maintains the structure of the stratified squamous epithelium. And if type 7 type of collagen is mutated, then it leads to the blistering skin diseases. So components of extracellular matrix: collagen, among which fibrillar collagen we read about them, and non-fibrillar collagen. The next one is elastin. So ability of any tissues to recoil and return to its baseline or its original structure after any physical stress, it is done by elastin. And this elastins are important in cardiac walls, large blood vessels, uterus, skin, and ligament. So, basically, the structure of elastin fiber is, imagine this is an elastin, okay, and it is this is an elastin. It is surrounded by the meshwork of fibrillins. Centrally, there is an core of elastin surrounded by this fibrillin meshwork. So, elastin. So any so if you consider these an elastin, so these elastins are cross-linked by hydrogen bonds with the enzyme, the same lysyl hydroxylase enzyme. So elastin is also cross-linked just like the collagen, but it differs by having an hydrophobic segment which is present at this end. So there is something called as an hydrophobic segment which is present at the end, and this hydrophobic segment um, forms an globular structure at the rest. So this hydrophobic segment will form a globular structure at the rest, but whenever a stretch is exerted in the tissues, this hydrophobic end starts opening up and it gives an elasticity to the tissue. But these cross links which are present between the elastic fibers maintains the tissue structure, tissue architecture, but this hydrophobic end just gives an elasticity to the tissue. And if the stretch is released at the end of any activity, then this hydrophobic end again refolds and attains this globular structure. So this fibrillin deficiency which are present as a meshwork around this elastin. So deficiency of fibrillin is seen in Marfan syndrome. So the clinical manifestations of Marfan syndromes are skeletal abnormalities as well as aortic wall, weakened aortic walls. And fibrillin also controls the availability of TGF beta, and if there is an excessive release of TGF beta, then there is increased activity of matrix metalloproteinases where collagen destruction takes place, leading to all the manifestations seen in Marfan syndrome. The next is proteoglycan and hyaluronan. So so there are these chondroitin sulfate and keratin sulfate. So these chondroitin sulfate and keratin sulfates are the highly negatively charged proteins which are attached to the core, that is called as an hyaluronan. Okay, so these bristles are called as an chondroitin sulfates, and this central core is called as an hyaluronan. And these chondroitin sulfate and keratin sulfates, which are the glycosaminoglycans, these are the negatively charged, so they will attract sodium and water, producing a gel-like matrix. So these proteoglycans and hyaluronans are hydrated gels which gives an resistance to any compressive forces seen in the joint cartilages. Also, it provides an lubrications between the adjacent bony surfaces. The next is adhesive glycoproteins and adhesion receptors. The first one is fibronectin. So this fibronectin is an dimer which are linked by the disulfide bonds. Examples of the fibronectins are collagen, fibrin, heparin, and proteoglycan. So this fibronectin helps in wound healing, scaffolding for the other extracellular matrix deposition. It also helps in angiogenesis and reepithelialization. Whereas laminin is a trimer having three ends. So this end is the binding site for type 4 collagen, this is for the heparin sulfate, and this is for the other extracellular matrix deposition. Laminin also forms a most important protein in the basement membrane. And third one is integrin. Integrin is an transmembrane dimer having an alpha and beta subunit, and the function of this integrin is it links or it adheres the extracellular matrix component. So it adheres both extracellular matrix component as well as intracellular cytoskeletons such as vinculin, actin, paxin, all of these. And also during inflammation, so integrin is present here. Okay, so during inflammation, these leukocytes, when they are flowing into the lamina of these blood vessels, so during inflammation what happens, these integrins helps in attachment of the leukocytes to the endothelium as well as transmigration of these leukocytes to the site of injury as well as inflammation. And similar action is also seen whenever there is a platelet aggregation. And these integrins also helps in locomotion of the cells we have just seen, and also in case of cell proliferation, differentiation, and maintenance of tissue architecture. So the next is proliferation of cell cycle. Why is this cell proliferation important? Because this is one of the most important mechanism for development, maintenance of steady state of tissue homeostasis, and for replacement of damaged cells. And the sequence of events results in cell division. All the sequence of events which results finally in the cell division, this is called as a cell cycle. And this cell cycle consists of G2 phase, G1 phase, S, G2 and M phase, and there are two checkpoints. The checkpoints which is present between the G1 and S is called as a G1S checkpoint, and the one which is present between the G2 and M is called as a G2M checkpoint. So what happens in the G1 phase? In the G1 phase, it is a pre-synthetic phase where chromosomal replication is occurring, whereas S is called as a synthetic phase. Okay, S for synthetic phase, where DNA synthesis takes place, and this is an mitosis. And just before this mitosis, this is called as a pre-mitotic phase, which occurs in the G2 phase, and M is in mitotic phase. And after the cell division, after the cell cycle completion, the cell will either undergo the cell division, or it will just enter into the resting phase, which is called as a G0 phase. So the cell cycles is regulated by both activators and inhibitors. Okay, and cell cycle progression is done by the cyclins and cyclin dependent kinases. And import we'll see types of cyclins. So cyclins are regulated by the cyclin and cyclin dependent kinases, whereas it is inhibited by cyclin dependent kinases, cyclin dependent kinase inhibitors. Okay, and yes, so there are basically two checkpoints. Okay, checkpoints are very important during the cell cycle. Why? Because this G1S checkpoint will ensure that whether there is any damage in the DNA, whereas G2S checkpoint, this will ensure that the cell which had an accurate the cell which had an replication, it whether it was an accurate replication or not, whether was there any DNA damage, or whether there was any unduplicated damage present, unduplicated DNA present at this point. Okay, and if there is no abnormality seen in this both checkpoints, then obviously the cell will undergo the cell division. But if there is any abnormality in this checkpoint in the cell cycle, then obviously the cell cycle progression will delay, and first this will enter into the DNA repair mechanism. uh, and obviously after a DNA repair after this DNA damage is repaired, then the cell cycle progression will take place. But if the genetic damage was too severe to be repaired, then the cell cycle undergoes senescence or apoptosis. In case, for example, there was an DNA damage, or there was an damage seen at this point, and it was not repaired by at this point, because the maybe because it was too severe to be repaired, then this unrepaired DNA will obviously continue into the cell cycle, and this type of defective DNA remains in the cell cycle and start replicating. So this can develop into an malignant tumor. So cyclin D, and so this is a cell cycle. Okay, G1S, G2M, and this is G1S phase, and this is G2M phase. And cyclin D, cyclin dependent kinase 4, 6, and 2 will regulate this G2S transition. Okay, 1, 2, and 3 will regulate this G2S transition by phosphorylation of this RB protein, whereas this S phase is regulated by this cyclin dependent kinase 2 and cyclin A, and cyclin B and cyclin dependent kinase 1 will regulate this G1M transition. And there are these cyclin dependent kinase inhibitors which will inhibit all these cyclins, so that cell cycle progression will not take place. And there are basically two families of cyclin dependent kinase inhibitors, one having these 4 proteins and the other one having these 3 proteins. Okay, and this 4 protein family is called as an INC4 INC4 proteins, which includes P16, 15, 18, and 19. This will inhibit only this cyclin D and cyclin D associated with cyclin dependent kinase 4 and 6, whereas this 3 protein family having 21, 27, and 57 will inhibit all other cyclins. So the next is stem cells. Usually the MCQs comes from the stem cells concepts also. I'll tell you further where. So this is the baseline population of the stem cells which are present in the body, and the function of the stem cells is either it will proliferate to a large number, or it differentiates into the other type of cell, or it also has a self renewal capacity where it renews its own cells if these cells number of cells reduced, or finally it undergoes apoptosis. So this is a zygote formed by union of an egg and a sperm. So this zygote develops into an blastocyst, and the inner cell, it is an inner cell mass. So this inner cell mass of blastocyst develops into an embryo. Okay, and this pluripotent stem cells, so this embryo has cells which are called as an embryonic cells or pluripotent cells. So the pluripotent cells are also called as an embryonic cells, which differentiates into the other lineage cells, like pluripotent cells develops into the multipotent cells, and then finally eventually leading to the lineage committed cells, and leading to the development of other organs. So there are two types of stem cells. First one is embryonic stem cells. As I said in this, so embryonic stem cells are the most undifferentiated type of cells. Embryonic stem cells are the most undifferentiated type of cells, and this gives rise to other lineage committed cells. Whereas pluripotent stem cells, this pluripotent stem cells has an capability of asymmetric division also, which means here it is seen asymmetric division. Okay, which means this pluripotent cells, one of the daughter cell will differentiate into the lineage committed cells, whereas the other has an capacity, and it retains the self renewal capacity. Okay, it renews its own cells. So these are the MCQs asked in NEET PG. So these are the adult stem cells. So in the brain we see the stem cells in subventricular zone and dentate gyrus, whereas skin, the stem cells are present in bulge of hair follicles. In the cornea it is present in limbus. Intestine, it is present at the base of the crypts, and in the liver it is seen at the canal of Herring. So this is the skin. So this is the bulge of the skin. So this is the area where stem cells reside, and this is an intestine, and these are the stem cells seen. This is the crypt, and this is the base of the crypt. So stem cells are seen at the base of the crypts, just below this Paneth cells. And cells of in the liver, it is seen in the canal of Herring. So it is depicted here microscopically. Thank you. We have come to the end of chapter 1. If any changes required, or if anything you felt good about the chapter, or any changes, or if any addition required, please let me know in the comment below. Thank you.